Welcome to the ICS 2020 online. My name is Marcio Averbeck, and I'll be chairing this session, which is entitled New Urodynamic Technology. And we are pleased to welcome all the delegates watching. Please use the comments functionality to say hello, ask questions, and participate in the debate. You can still post questions after the event, and the faculty will have a chance to respond. This roundtable focuses on new urodynamic technologies that are currently being investigated and may play a role in the diagnostic workup of patients with urinary tract dysfunction in the future. Let me share my slides with you. So, these are my disclosures. Today, we are going to count on a very special panel of experts, and let me introduce them to you. So firstly, Professor Enrico Finazzi Agrò, Associate Professor of Urology and Chair of Urology Unit, University of Rome, Tor Vergata. Professor Adam Klausner, Neurourologist, Warren Cons Professor of Urology, Director of Neurourology and Void and Dysfunction, Associate Chair for Research, Department of Surgery, Virginia Commonwealth University School of Medicine in Richmond, Virginia. And last but not the least, Professor Margot Damaser, PhD, Cleveland Clinics and Cleveland VA Medical Center, Cleveland, Ohio, United States. We all know that urodynamics are the mainstay of diagnosis of urinary tract dysfunction. However, there are some inherent limitations of current urodynamic technology. Firstly, pain or discomfort while inserting the catheters. Not only this, but also the risk of urinary tract infections. And we all know that standard urodynamics provides only a snapshot of urinary tract function. And we all know that sometimes a snapshot may be somehow misleading. Take a look at this study, which has been published many years before on neurourology urodynamics, showing that across several rounds of urodynamics in the same patients, there was a poor correlation in several urodynamic parameters. The authors concluded that the lack of repeatability of urodynamic studies may be related to physiological fluctuations in bladder function and also inherent related insensitivity of the instruments that we are using nowadays. Ambulatory urodynamics has been proposed to overcome some barriers, but we all know that ambulatory urodynamics are not widely available in different countries. So let me start asking Professor Enrico Finazzi Agrò to deliver his lecture, which is entitled, Is There a Role for Non-Invasive Penile Cuff Test? Enrico, please. Thank you for being with us.
Thank you very much, Marcio, for the nice introduction. I think I was able to share my slides with you. So my role is to describe the role, if any, for this non-invasive test, this so-called penile cuff test. These are my disclosures here. And starting with the topic, we know that LUTS in general and specifically in male patients may be due to different conditions, different causes. Among them, one of the most relevant is certainly the benign prostatic obstruction. But we know also that to diagnose benign prostatic obstruction, we need invasive test. We need invasive urodynamics, and basically the only way to have a diagnosis of BPO in a single patient is to perform a pressure flow study. Also, because it is important to evaluate the presence of BPO or of detrusor underactivity, or both conditions that may be present in the same patient. So we need an invasive test, but on the other hand, we don't use invasive tests in all patients, as Marcio already explained us, because it is time-consuming, because it requires expensive equipment and skilled staff, and also carries the risk of urinary tract infection. So we don't routinely investigate with invasive tests our patients. So what can we do in alternative? We can use urodynamics or non-invasive urodynamics. I would like to remind you that urodynamics is the investigation of the function or dysfunction of the lower urinary tract with any appropriate method. So even if we use ultrasounds, for instance, or other technique, we are making a urodynamic test at the end. And this is the case, for instance, for intravesical prostatic protrusion that has been proposed to investigate the risk of obstruction in a patient, or to assess the urethral prostatic angle. That is another way to assess the risk of obstruction. The same can be said for the detrusor wall thickness, another possible parameter, or even the sophisticated study with magnetic resonance during voiding may be used as a urodynamic test to understand the dynamic process of the micturition. But among all these tests, probably the penile cuff test is the one with more evidence, more studies below what we know now, and I mean with a good history, let's say. I will try to be very brief in explaining the history and the potentiality of this test in the next few slides. What is the principle for this study? The principle is basically the same that we use to diagnose the systolic blood pressure. So we, in that case, we fill the cuff and we stop the blood flow. In this case, we fill a small cuff around the penis, and we stop the urinary flow during the micturition. And with this stop, we will evaluate what we call the isovolumetric bladder pressure. Isovolumetric bladder pressure is an expression of this is a brief summary of the test. I was saying that it was a volumetric test is let's say a tool to investigate the detrusor function. If we have a patient with a low flow but a high isovolumetric pressure, then a normal detrusor function. In that case, probably there is a BPO or anyway a bladder outlet obstruction. If we have a pressure with a low flow, sorry, a patient with a low flow and a low isovolumetric pressure, there will be detrusor underactivity. So on these basic principles, and also there was a development of an automatic system that is called CT3000, allowing simultaneous flow recording and also multiple evaluations during a single micturition. Here we see the typical traces coming from this test. Here you see the increase of the penile cuff pressure. Here is the moment where the flow stops, and this is the isovolumetric detrusor bladder pressure recorded for this patient. This is a very brief video. You see here the patient is urinating. The flow starts. Here you see there is an increase of the PCAF pressure until a certain point. You see here the flow goes down, and here around 150, let's say, centimeters of water, the flow stops, and then the cuff is emptied, and the cycle starts again. At the end, you will be in few seconds. At the end, you can record several cycles during one single micturition. We have the ICS nomogram to be used for invasive tests, and the idea of the authors that proposed this originally this test was mainly investigated in Newcastle and proposed by those authors. And you see when, of course, when you compare the ICS nomogram with the nomogram coming from isovolumetric pressure, you have to change, of course, something, because isovolumetric pressure also comprise some abdominal pressure, and also the cuff is a little bit lower the pubis bone, so the point of reference for an invasive urodynamic test. So the interception of the line is not at 40 centimeters of water, but it was moved to 80 centimeters of water, and also the slope of the line was changed because the isovolumetric pressure rises during the interruption of the flow. Here is the nomogram proposed by Griffith and other authors, and here you see there are different parts in this nomogram. Here on the right side, you will have let's say people voiding normally. In the upper part in the left, there are the obstructed people. And authors were able to correctly classify around 70% of patients with a very good, especially negative predictive value, around 90% for obstruction in this case. We also conducted a study some years ago in my center, and in our case, we were able at the end to find a negative predictive value of 100%. So we were able to exclude basically all the patients not having an obstruction in our series. Here you see that this test can be used to evaluate different situations before and after surgery. You see that the patients move from this part, from the upper and left part to the lower and right part, so to the normal voiding situation after a TURP. And also another very important point is that this test was found to be able to evaluate obstructed, equivocal, and unobstructed patients, and the success rate of a TURP in these different categories of patients was different. Obstructed patients had a rate of success around 90%, whilst the unobstructed had a success rate of around 56%, so much lower. Limits. Of course, there are some costs for this test. It's more costly than a normal uroflowmetry, but it is less costly than a pressure flow study. In Italy, the cost for a cuff is around 30 euros. And the other point is what is the real value for this test? And we know that the European Association of Urology guidelines do not recommend in this moment non-invasive test, because the evidence is not still so adequate to recommend this test in alternative. Probably the PCAF is one of the most studied among of these tests anyway. And also in the EAU guidelines, there are some limitations also to the recommendation of an invasive test, even before surgery. So even, I mean, before surgery, the invasive tests are not always recommended. And the situation may change further after the publication of the upstream trial by Marcus Drake and co-workers, where urodynamics was found not to be able to change the surgery rates or the outcomes after treatment. So this message, even if the message of the study was not that urodynamics is not important before surgery, but only that sometimes the quality of urodynamics is not good in all centers, and anyway the surgery rates are not changed. These are the main messages, but this kind of findings may provoke a reduction, a further reduction of the use of invasive urodynamics before surgery. But why to perform a urodynamic test before surgery? We know, for instance, from this Japanese study, that the success of a TURP is related to the presence of BPO. So the patient is successfully treated if he is really obstructed before surgery, and is related to the absence of the drusen underactivity. So if we have a pure underactive patient with no BPO, probably the rate of success will be lower in that patient. And we know from this systematic review, you see here that the success rate in terms of IPSS and improvement of Qmax is lower in patients with underactivity in comparison to patients without the drusen underactivity. And also from these older studies, when again patients with the BO had such success rate of around more than 90% compared to 78% in the group classified as non-obstructed. So still you can operate on those patients, but the success rate that you can expect is lower. So in this way, probably this test may have a role, because in using this test we may be able, this is a non-invasive test, so without all the problems related to the invasiveness of a pressure flow study, you may be able to understand which patients are really obstructed. Those patients will have the higher probability of success after surgery, and which patients are not really obstructed. So in those patients, you can expect a lower success rate, and you may have a better counseling of these patients before surgery. Yes, I'm going to conclude. These are my conclusions. So the penile cuff test has good proof of concept data. All the basic principles were investigated and proved to be consistent. The clinical data are good. Still, the evidence is not strong. So we need, of course, more controlled studies for this technique. It is more expensive than uroflowmetry, but less expensive than the pressure flow study. It is able to correctly classify around 65 or 70% of patients, thus possibly avoiding the need of invasive urodynamic test, and could be used for sure in the pre-surgery evaluation to limit the use of invasive tests, or even when first-line therapies are not effective as an alternative to an invasive test. And with this, I would like to thank you for your attention.
Thank you very much, Enrico, for such a comprehensive lecture. And I would like now to invite Professor Adam Klausner to present his lecture, which is entitled Urodynamics 2.0, Next Generation Urodynamics Using Ultrasound. So, Adam, welcome.
Hi, thank you very much to the ICS and the moderators for organizing this amazing talk. Again, my talk is Urodynamics 2.0, Next Generation Urodynamics Using Ultrasound. Here are my disclosures. So I want to start by asking the following question, which is, which imaging modality do we think is better during urodynamics? We have the gold standard fluoroscopy, where we get two-dimensional low-quality images that have associated radiation and have a large footprint, or ultrasound, where we get three-dimensional high-quality images without radiation and a small footprint, enabling the capturing of three-dimensional structural images of the bladder. And so I think, having laid the groundwork that there is a role for ultrasound during urodynamics, our goals for next-generation urodynamics or ultrasound urodynamics include: 1, the development of ultrasound metrics to evaluate bladder shape, and 2, development of ultrasound metrics for the evaluation of bladder wall micromotion. So let's start with bladder shape. So the first thing we wanted to do as a group was come up with some way to compare individuals with different bladder shapes. And so we thought the simplest way to do this was to look at diameter ratios. So for this study, we had women enrolled who had either overactive bladder or no overactive bladder based on ICIQ overactive bladder surveys. They then underwent prospective ultrasound urodynamic studies where images were acquired every 1 minute during filling. And then we measured diameters, including height, width, and depth at bladder capacity. And you can see representative examples of these images on the right. And then we calculated the height to width diameter ratios. We then plotted the height to width ratios in normal. You can see the red dots here. These are the normal individuals, no overactive bladder, no lower urinary tract symptoms. We created 95 confidence intervals, that's the horizontal bars, and then we plotted the height to width ratios for the overactive bladder patients, and you can see that in blue. And what we found was that none of the normal patients had bladder shapes outside of the confidence interval, so their height to width ratios were within those bars, whereas 5 of the 11 overactive bladder patients, or 45%, had shapes that were outside. So here's the cluster of the normals, and here's the cluster of the overactive bladders that are outside of bounds. And so what that showed us was that there are different bladder shapes that we could identify, including those with high height to width ratios. So it's elongated. So we came up with a fruit that might represent that, an eggplant. You have the normal or round bladders, and then we have pancake-shaped bladders. Those are going to represent those on the top with low height to width bladder ratios. And what this really showed us is that you could use this very simple method of comparison using height to width diameter ratios as a shape metric to identify bladder shape changes that potentially could be associated with overactive bladder. And this data was published recently in Female Pelvic Medicine by our group. So this brought us to some next questions in this area. And the first was, are perimeters better measures of shape or shape irregularities of diameter ratios? Because diameter ratios really are just measuring the bladder one-dimensionally. And so diameters are really going to measure the whole bladder. The second was, are shapes consistent throughout filling, or do they potentially change during filling? Because our first study really looked at the bladder shapes at capacity and not as a function of filling volume. And the third was, we were looking at data during urodynamics, but potentially there could be differences between urodynamic filling versus natural filling. So our next method was to use a technique we call perimeter analysis. And for this study, we enrolled women with and without overactive bladder based, again, on the ICIQ OAB surveys. We acquired 3-dimensional images every 1 minute during ultrasound, urodynamics, and every 5 minutes during a natural filling diuresis study where we had patients drink 2 liters of fluid very quickly and then had them measure their voiding function over several hours. And then at each volume, we manually trace perimeters in the transverse plane. You can see the yellow dots as shown here. We repeated measurements for 6 cross-sectional planes 30 degrees apart. And the good thing is the use of 3-dimensional ultrasound allows simultaneous acquisition of this. So you're not moving your hand. So all of these images are at the same hand position. And they're captured, and you can see the images obtained at one specific volume for one individual patient here. Okay, so what this enabled us to do was to measure and record shape parameters, including diameters, perimeters, and cross-sectional areas. And then for each bladder, we generated a 3-dimensional reconstruction. You can see that on the bottom right to give visual confirmation of what we're looking at. And we found that the sagittal perimeter was found to have the best variation with volume. And so we wanted to start by using this data on normal patients to create a nomogram. All right, so this is what we did. We had sagittal perimeter values plotted as a function of volume. And we can see the nomogram here. We use a power model with lower and upper bounds of 95% confidence intervals. We generated the nomogram using sagittal perimeter volumes between 100 and 500 mLs, and then had 533 sagittal perimeters from 27 women without OAB. This is normal, healthy volunteers who enrolled in this study, including 14 who underwent urodynamic studies and 13 who underwent these natural filling hydration studies. And then we wanted to test a nomogram. So we then brought 5 patients with overactive bladder, and we used their data against this nomogram to see how they fit. So we had 264 sagittal perimeters from 24 women with overactive bladder, again, defined by surveys, including 16 from urodynamics and 8 from hydration studies. We defined abnormal shape using an iterative process where the sagittal perimeter values outside of the nomogram bounds for 3 or more values was considered positive. So again, in order to have an abnormal shape, you had to have 3 values where your perimeter was out of bounds. And what we found using this definition was that for our overactive bladder women, about 21%, or 5 of 24, had abnormal shapes based on abnormal perimeters outside of the nomogram bounds. And there was a significant association between abnormal shape and overactive bladder survey status as well. And you can see how the data is plotted, where each symbol is focusing on an out of bounds shape. So here's some examples of what we were able to find with this new perimeter method, which is here's the normal bladder. You can see a nice round bladder, and here's an OAB outlier. And you can see that the difference between this perimeter analysis and simple diameter ratio analysis is that you can pick up irregular bladder shapes, as shown in the example here on the right. And ultimately, we feel that this could be used as a non-invasive way of identifying a shape-associated subtype of overactive bladder. Okay, so the question that some people might ask is that this is an extraordinarily labor-intensive process. We have gigabytes of imaging data acquired at every single volume, 6 different planes at every single volume, and we're talking about a tremendous amount of data and a lot of labor to trace each individual bladder perimeter to get this data in this nomogram. And so I have a team of research people working with me, but what we want to do is ultimately automate this process. So we've teamed up with our computer science people, and they developed a preliminary algorithm to shape every single bladder image, and it can be done for an individual, and it can be done with a matter of seconds. And you can see how it does this here. And then it creates a 3-dimensional reconstructed shape with every single perimeter being traced. You can see that the algorithm, this first iteration, really underestimates the true bladder shape. And so this is something that is a development in progress, but it does demonstrate potential that automation of this could be done so that it could ultimately be scaled up for use in clinical practice. Because the concept is we want to have something that during the urodynamics you could ultimately be able to use and give to your patients immediately rather than having to wait a couple of days for post hoc analysis. So this would be the future of that as well. Okay, so let's talk about bladder wall micromotion. Low amplitude rhythmic contractions have been seen in many individuals with detrusor overactive or bladder outlet obstruction. You can see an example in urodynamic tracing here. And that synchronization of micromotion in different regions of the bladder is thought to be related to these pressure changes. So we had 2 goals. One was to develop a method to evaluate these pressure changes in the bladder and be able to quantitate them, and then to develop an ultrasound method to see if what we're seeing with the urodynamics in pressure fluctuations actually correlates with ultrasound, so that ultimately there could be a non-invasive way of identifying this. Okay, so I'm going to go through the algorithm real quick because it's a little bit engineering heavy, but this is the automated algorithm for the detection of phasic detrusor overactivity. We extracted the PVES and PAB from urodynamics. We then do something called a fast Fourier transform, which identifies the frequencies with scaled amplitudes. You can see a peak here at about 2 cycles per minute in the PVES, not in the PAB. Then we do an algorithm to tell us if this signal is independent of PAB and also is of high enough significance to be an independent signal. And then we overlay the generated waveform so that the urodynamicist can actually see the frequency overlaid on the PVES tracing. And this can all be done real time. It takes about 2 minutes and can be done real time. And this identifies a rhythm that is both significant and independent. We publish these results in PLOS ONE with our team. And so then the next step was to develop a micromode detection method using ultrasound. And so for this, we used a texture tracking algorithm with anatomic M-mode ultrasound. We had 19 women with overactive bladder, 13 with overactive, 6 without. We did prospective ultrasound urodynamics. Filling was paused at 40 and 70% so that we can get data without the artifact of the pump. And then we took video loops for about 90 seconds for each and did this texture tracking algorithm. You can see here's an example of this. M-mode ultrasound allows ultrasound to be taken on a linear basis. So we're looking at the wall in 1 dimension here so you can track wall thickness over time. What we do is we have the patient cough at the start of the study so we can mark that and we can see that on the video afterwards. And then again, just to take you through the algorithm here, we mark the bladder wall. The algorithm tracks the initial location to a new location in subsequent frames. It then traces the wall thickness and generates a waveform based with the FFT. And then we overlay the waveform onto the actual PVES so that we can do a correlation. Here's an example of a patient with overactive bladder. You can see the bladder wall moving all over the place, and an example of a patient without overactive bladder, nice, still, flat wall. And when we actually looked at the data, we defined micromotion as wall changes with peak frequencies in the range we were looking for at a significant amplitude. Here we used 0.14. All participants with high amplitude using this definition were found to have detrusor overactivity, so 100% specificity, and no patients without micromotion were found to have DO. So it was like a subtype. And this demonstrates the feasibility of non-invasive ultrasound cine analysis to identify micromotion. and it, again, identifies a potential micromotion-associated overactive bladder subtype using non-invasive ultrasound. So in conclusion, next-generation urodynamics using ultrasound are feasible as most urology and urogynecology offices have the necessary equipment and experience. Ultrasound urodynamics can potentially be used to identify shape and micromotion-associated subgroups of overactive bladder. I'd like to thank everybody for their time, and also pleased to emphasize that this is a group effort with many, many individuals from all walks of life, including engineering, students, postdocs who all contributed to this. So thank you very much for your time.
Thank you very much, Alan, for, wow, this is amazing, newer insights on micromotions and ultrasound. So I have some time to discuss in the Q&A session at the end. I would like now to invite Professor Margot Damaser to deliver her lecture, which is entitled Wireless Catheter-Free Technology for Monitoring Bladder Function. So, Margot, we are very happy to count on you two here in this panel, and we are looking forward to breaking through the data that you're going to share with us. Be welcome.
Okay, can you see my slides and hear me?
Yes, perfectly.
All right, so I thank you for inviting me to join this terrific session and speak along with my esteemed colleagues and our moderator. I have some disclosures relevant to this research. The point is to get the technology into the clinic, and the way we will do that is by working with the companies. So I do that, but my travel to my home office from my kitchen where the coffee is was entirely self-funded. So you heard a little brief overview from Marcio about urodynamics. It is the mainstay of diagnosis of lower urinary tract dysfunction, and it has advanced the field tremendously from where it was before, but it does have significant limitations. It only provides a snapshot of bladder function, and it is therefore not always able to reproduce patient complaints. In some populations, up to 50%, it cannot reproduce a patient complaint. It involves an artificial situation in a clinic with a couple of catheters inserted into the bladder, and then the rectum or the vagina, retrograde filling of the bladder. It's uncomfortable and embarrassing, and it involves expensive specialized equipment in a specialized laboratory. So we've been, my group, we've been discussing for a number of years, like how we could improve on urodynamics, and we've come to the conclusion that the catheter is the problem. And if we could get rid of the catheter, we could not only improve urodynamics, but we could open up chronic monitoring and therapeutic options. And I'll discuss some of those a little later in the talk. So we've been working on this idea of wireless catheter-free urodynamics for about 15 years. Now, catheterization is also a problem in animal studies and in research. Most urodynamic studies in animals, particularly large animals, are done under terminal procedures, under anesthesia, and that's because of the catheters, again, so that the animals will tolerate having catheters. And the anesthesia affects the neural reflex, it affects voiding function, and it changes the experiment. Now, we can do studies with a catheter implanted suprapubically, but that also affects the experiment. It can make bladders irritable and overactive, and it changes the experimental situation, where what we'd really like to do is study the animals in conscious ambulatory normal conditions. So what does it mean to go catheter-free? Well, for the patient, it could be more comfortable and private, voiding by themselves as if they have a Holter monitor for their bladder. That's collecting data while they're able to go about their normal daily activities. It should be able to improve diagnosis because we are monitoring during normal daily activities, not in an artificial situation. And we're optimistic that it will be able to provide a better differential diagnosis, but we're not there yet. So for the clinician, it means that we can obtain data during natural filling and voiding cycles. And if we can monitor over a longer period, the way Holter monitor does for the heart, there's more opportunities to confirm symptoms over days. It's not just one snapshot. And it opens up the possibility of chronic monitoring, as I alluded to. For the clinic, the idea is that a device could be placed by nursing staff, and it's designed to be removed by the patient themselves and thrown away, and all the data has been wirelessly transmitted and up to the cloud. So it eliminates the need for specialized personnel to run the study. And the wireless connectivity eliminates the need for specialized equipment. So our concept for wireless catheter-free monitoring involves a device inside the bladder that wirelessly transmits pressure and volume to an app on a phone that the patient would have with them. And in the app, the patient could input sensation of urge or pain. They could input when they have leakage. They could input what activities they are doing. And this would be synchronized with the data from the device inside the bladder. And then this would all be streamed up from the phone to the cloud, where it could be reviewed by a clinician. We envision that somebody would have this device in place for maybe 2 to 7 days, maybe an average of 4 to 5 days of monitoring during normal daily activity. And it could be removed by the patient themselves with a string attached to the device, as you see here. Now, no busy physician wants to review 7 days of 24 hours of data. So we have also developed proprietary diagnostic algorithms that identify features in the data. They don't run the diagnosis for the clinician, but they can identify features so that the clinician knows where to look. And in addition, our algorithms can estimate detrusor pressure from vesicle pressure alone, eliminating the need for a second catheter. Unfortunately, I don't have time to go into the details of those here, but we have published some of that data. So the device that we have developed, we call the Uromonitor, and it consists of flexible electronics and a battery inside a pre-stressed silicone housing. And I have one here. You can compare the size of it to my face to get a sense of how large it is. It straightens out to be inserted, easily straightens out, and then it curls back up on its own once it's released into the bladder lumen. And this design is meant to both prevent it from blocking the outlet and becoming obstructive, and prevent it from being voided out. The only stiff part is here at the end is the battery. Everything else is flexible. And we can attach a sterile suture to one of the end caps here at the end and leave that out of the urethra, much as is done for a stent, and it can be easily removed by the patient. Now, we've been able to do what I call phase 0 clinical testing. It's phase 0, not phase 1, because the device isn't used as we envision it to be used clinically. It's only used in the urodynamics lab and only in for about 2 hours. But it allows us to get simultaneous data with urodynamics and to get a sense of ease of insertion, ease of extraction, comfort of the device in for a couple of hours. So this shows a cystoscope picture of the Uromonitor inside a woman's bladder. And it shows also in panel A, the suture attached to the Uromonitor that it's removed by. And we found that the Uromonitors were easily inserted and easily extracted, relatively comfortable while they were there. This is a study done by Samir Derisavaford, a fellow who was a fellow at the Cleveland Clinic under Howard Goldman's supervision. And it's presented as an on-demand abstract at the ICS, abstract 201. So for details of this study, please do check out that abstract. Now, we were able to do some simultaneous measurement by the Uromonitor with urodynamics catheters in place. And what you see in this panel, the top figure has the vesicle pressure from the catheter-based urodynamic measurement, and the second trace shows the Uromonitor. Both pressures are pretty comparable. The vertical arrows show where voiding begins, and both show voiding. quite well. And then we were able to remove the urodynamic catheters and allow the woman to walk around our urodynamic suite while she drank water until she felt the need to void. And this is an example of the data we captured during that period. The arrow again indicates where the void was. The variability in the pressure data shows her walking around. And that's, when we blow it up, it's exactly timed with her pacing. And you can even see where she turned around as we were walking back and forth inside the suite. For voiding, when she felt the need to void, she went into a bathroom, voided privately by herself, and we were able to simultaneously watch the data coming in by Bluetooth on our laptop outside the door. So it really eliminates the need for somebody to watch during voiding, and she can do everything privately. And again, if you want details on this study, check out On-Demand Abstract 201. Now, we're also working on a experimental device for research use only, and this is sized for cats. This we call the urologic monitor of conscious activity. It is inserted into the bladder lumen suprapubically, so it does involve a surgical insertion, and it also measures pressure, and I have one of those with me too. It's a little tricky to see, but you can see the size of it next to my face here. What's nice about this device is that we've also been able to instrument it to measure volume. Now, I can buy a pressure sensor, and that's the little metal silver column you see on the red background of the board, but I cannot buy a volume sensor. We've had to develop our own volume sensing technology. And for more details on this, check out Steve Majerus's presentation, Abstract 254, which is live Sunday, November 22nd, as part of the Best of the Basic Science session. And he'll go through more details of how this device works, but I get to show you some of the data here. And actually, I get to show you my favorite cat video, which you won't find on YouTube. This was when we only had the Uromocha instrumented for pressure, but what it shows is that the animal wears a backpack with a radio to receive data from the little device inside its bladder. And then the animal can be freely moving while the radio transmits this data via Bluetooth to our computer. And the pressure trace on top is synchronized roughly with the video of the cat using the litter box. And you can see the backpack he's wearing with the radio. And then he's going to start voiding, and you can see the pressure rise for voiding and then decrease. And then he will finish voiding and leave the litter box. And this is exactly what we see come across our computer as we watch the animal use the litter box. And again, more details are in Abstract 254 in that Best of Basic Science session on Sunday. So we have now, since that video was taken, instrumented the Uromocha to measure volume. And this is really new data, just out of my lab in the last few weeks. And we have pressure trace on the top in black and simultaneous volume measurement in green on the bottom. And you can see the volume increases during filling. And then we have a blow up of that blue rectangle area on the right for voiding. And you can see that the volume decreases during voiding. The flat line in pressure there at the end in the right-hand panel is actually where the experimenters decided they were done measuring and pulled the radio off of the device, and that's where the radio lost contact with the device. So what's the future potential? If we get rid of the catheters, there's really a lot of potential for this technology beyond diagnosis alone. So one of the things that we would be able to do with a longer-term indwelling device that can give bladder status continuously is provide sensory restoration for individuals who have lost sensation, such as diabetics and those with spinal cord injury particularly for those who have to use clean intermittent cath to empty the bladder. Right now, they catheterize based on the clock, but we could connect the device to an app on the phone and notify them when they need to empty their bladder, whether that's based by increasing volume or increasing frequency of non-voiding contractions, perhaps, or other parameters from the bladder function. We can also provide conditional neuromodulation, which we think would be an improvement over the always-on stimulation paradigms used now for particularly sacral nerve neuromodulation. It should open up new populations and new possibilities to only provide the stimulation when it's needed based on real-time feedback and bladder function provided by a chronic monitor inside the bladder. And Dr. Majerus has a second abstract, 255, also part of this Best of Basic Science session on Sunday, with our preliminary data in sheep using the Euromonitor for conditional neuromodulation studies. And the last application is really personalized medicine. So if we put someone on a new treatment, we could give them a Euromonitor to go home with for a week or longer, and then adjust or tweak the treatment based on objective data during activities of daily living. And we expect that that would allow finer titration of treatments and really personalized medicine in our field. So this work is not possible by myself. I have a lot of colleagues working with me, a lot of students who have come through over the years and have contributed greatly to this research. And I'm immensely grateful for our funding sources for this research, and they've hung in there with us during difficult times when things weren't working out. I'm particularly grateful for two colleagues who have passed away during the course of the research and haven't been able to see it come to this point where we're able to do clinical testing and really have some good results to present. Dr. Averbeck and Dr. Coe were essential collaborators from engineering at the beginning of this research. I'm very grateful for Steve Majerus, who is an electrical engineering PhD and really the brains behind the low power wireless electronics that's inside the Euromonitor. And Robert Karam developed the algorithms that we use for real-time analysis, enabling conditional neuromodulation and estimation of detrusor pressure. Samir Deri-Saviford and Howard Goldman ran the clinical study, and I'm grateful to them for that as well. Thank you for this opportunity to present, and I'm happy to take any questions.
Thank you very much, Margot, for this amazing lecture on neurotechnologies. So we have some questions from our delegates from the audience, and I'll start with Enrico. Enrico, firstly, congratulations once more for such an amazing and comprehensive lecture. And I would like to ask you some questions which were made by Professor Rosier. Peter Rosier. He mentioned that most probably the non-invasive examinations in urodynamics are somehow indicated to assess the grade of obstruction, the diagnosis itself, but are not necessarily related to the outcomes of the treatments that we are offering. So I want you to answer his question concerning the role of urodynamics in this non-invasive tests, such as the penile cuff test, and what do you envision for the near future concerning these tests? Is further research still needed?
Yes, thank you, Marcio, and thanks to Peter for this question. Yes, Peter knows very well what I think about this point. I think that if we ask to a test to improve the outcome of our surgical treatments, we should change in some way our clinical conduct, our clinical decision after using this test. But for instance, in this case, basically all the patients studied at the end are treated by TURP or another disobstructive treatment anyway. So it is difficult to believe that this test may change the outcomes of our patients in that sense. Peter is suggesting, and I agree with him, that if we are able to understand in which patients our surgical treatment is really not indicated, we could exclude those patients from the total of the patient we would operate on. And in this way, we would improve our success rate. We aim to have a success rate of 100%, not 70%. So this is the idea. Coming to your question, Marcio, what is the role of this test in the next future? I believe that it may help us to not use some invasive tests before surgery, but also that it may be used for understanding better the so-called clinical progression of BPO. We know that BPO is a progressive pathology. Using this test in alternative to an invasive test that is more difficult to use in the general population, I think that we may understand better how to manage and how to study our patients during their follow-up.
Thank you, Enrico. Well, moving forward, Adam, Peter also wanted to know from you whether the validation of the methods that you've just discussed were against OAB syndrome or against detrusor overactivity. Could you please let us know?
Yes, so I apologize, and part of it is likely because I was going so fast for the data, but for the shape metrics, those patients were validated against overactive bladder syndrome based on the ICIQ OAB survey, because only half of the patients actually had urodynamics, the other half were just under hydration studies, so we didn't have a gold standard. But for the micromotion, we were actually trying to compare micromotion assessed overactive, micromotion assessed by ultrasound versus pressure fluctuations assessed by the algorithm that we created. So we're really comparing that against detrusor overactivity and not overactive bladder. I hope that answers.
Thank you, Adam. Something else, is the technique for the micromotion detection with the current available ultrasound devices feasible? Any tips for the researchers that are willing to dive into this research field?
Yeah, so the way we originally found out about this was, one of my residents brought in a picture of her unborn child, and you could see that the picture looked so high definition that you could actually tell that it looked like the father just based on the ultrasound. And so every urogynecology department or office has three-dimensional ultrasound. It's widely available, not as much in urology offices, but you don't even need the 3D application for some of this. The micromotion, which is M mode, is linear. That's on almost every commercially available urodynamics machine. So really something that would be readily available in all offices.
Thank you very much. Margot, lots of questions for you, So I'll try to start from somewhere, but we have plenty of questions. So let's start with a question from Gomert van Koberich. Hello, Gomert, and thank you for attending this session. He says that he's excited about your data. The data has been presented by Margot. And how do you measure the abdominal pressure, Margot?
Yeah, that is a very good question, mostly because we propose that measuring abdominal pressure is not necessary. And that really comes from the algorithms we've developed. They're not too different from the fast Fourier transform, the FFT, that Dr. Klausner mentioned for his technology. We use a wavelet-based technology, which adds to the FFT a sort of pattern recognition. This is my very basic understanding of the computer science, electrical engineering technology. But we can pick out from the detrusor pressure, from the vesicle pressure, which we are measuring, the bladder contraction pattern or typical shape for that person, and then subtract out the abdominal pressure, and we can estimate detrusor pressure and abdominal pressure from the vesicle pressure. We have a couple of
Okay.
papers on that.
So very straightforward answers now, Margot. We have limited time. So 2 questions
Okay.
for Mohammed Goma. For the Euromonitor, do you had any patients who had passed the device during urination? And for this Euromonitor, again, are you working also to integrate volume sensor as the one used in animals?
Yeah, so I'll answer the second one first. We are applying for funds to integrate the volume sensing. It's not trivial. It involves attaching electrodes to the outside and passing wires through the packaging without disrupting the packaging that isolates the electronics from the urine. So that is our intent, was to use the animal device as a test bed and then integrate the volume into the human device, the Euromonitor. And it's an interesting question about passing the device, because one of our subjects, a woman, passed the device during voiding. And we asked her what it felt like, and she said it was not painful. It just felt like something non-fluid coming out of her urethra. And she had a very open bladder neck and stress incontinence. And so there may be some patients for whom this shape, this design is not appropriate. The good news is that it was not obstructive.
Thank you. Thank you very much, Margot. So we are out of time, and I would like to thank you for participating in this live event. Please continue to add questions and comments so that the faculty can respond on the chat. And thank you for watching. And please find the next live session on the program page. Thank you very much.
Okay, thank you.
you.